I should say good afternoon to everybody. It's a pleasure to be here, and I'm very impressed that people come on a Sunday to spend the Sunday discussing nutrition and cancer. When we look at this topic, it becomes obvious that, yes, prevention is a life course approach is crucial, and we've heard that cancer usually strikes in the latter ages. So the question that comes up is, what can we do from early on to prevent the later events? And interesting enough, it was pointed out by Phil, there are things that we can do at every stage of the life course. So when we talk about life course, it's not only exclusive to the early years, but at every stage of the life course. And there's obviously the tendency to look at cancer from the standpoint of the time of diagnosis, but the real question is, what can we do in the early life so that we don't have a diagnosis of cancer? It's not an obligatory event in the life course. And this is part of the arguments I will develop over the next 30 minutes. The cancer biology is determined by early life events, maternal hormones exposures, even during fetal life may have an impact in the next generation. The example of vaginal cancer in offspring of women treated with diethylbestrol to prevent abortion is something that is worth pointing out. We also have the events linked to early carcinogens in childhood and even in fetal life. We have also the events around early growth, starting with birth weight and the growth of infants, and the timing of life course events, like the timing of first menstruation, so menarche, and the pubertal maturation as critical events, at least in some types of cancer. We have the early feeding, including breastfeeding, as a way of conditioning both growth and dietary patterns later in life that are within our control. In the cancer report, there is also the identification that attained height may be relevant for some cancers. And of course, diet and physical activity behaviors are shaped on early on in life, thus determining the exposures for lifelong risk. At the same time, there could be special sensitive periods in which the cancer susceptibility is greatest, and we need to be concerned with those. Smoking would be one of those examples. I'm putting these curves not so much to point out the exact numbers, but this is age-related events regarding incidence. And if you can see, cancer is not a random event. It usually occurs in men and women, both incidence and mortality, after the reproductive years. So if indeed cancer is conditioned by genes, this is evidence that it is after you have fulfilled your reproductive potential where the cancer strikes. If cancer was to condition early death, those genes in fact would not be passed on to the next generations. So there's a selective process by which we try to get rid of the genes in the pool that would promote cancers early on in life. The view of the cancer process being a lifelong process, it's not new. It's been highlighted already about 15 years ago in a paper in Science, and it obviously the genetic polymorphisms define the way we handle both nutrients and toxicants, and in a way are defining the cancer susceptibility. We're exposed to different nutritional inputs, and that also will condition the way we react to that. Within the environment, we're concerned with environmental pollutants that also are interacting with both nutrients and the genetic environment to define the cancer process. And of course, smoking as being one of them will also generate this enhanced cancer susceptibility. And the concept of having one hit and then an expansion of that genetic change through environmental changes and susceptibility is also central to the cancer process and the cancer disease outcomes. So the idea is, yes, we have genetic susceptibility, but the real question is, what can we do to keep it at the lowest rate? And in a way, what can we do at fetal life, in infancy and childhood, adolescent, adult life, to actually keep this to a minimum? So our job would be, in this process, to actually reduce this accumulated risk. So we obviously acknowledge that there's genetic susceptibility, but what can we do to keep this at its lowest rate? If we look at the evidence, nutrients sometimes and toxicants come in the food supply, either the food and water. So lifelong exposure, as evidenced by some of the measures that have been taken, one example of this is the Lord Boy cohort that was studied before the war and then followed over 40 years later, showing that over that 1 week of life, 1 week of time, that diets were studied, families that had increased intakes of energy, in fact, 40 and 50 years later, had higher non-tobacco related cancer rates. So showing that early exposures at that point was, I think, around 6 to 7 years of age, had an impact on the cohort later on in terms of cancer risk. The idea of growth and body composition affecting cancer rates is true for all of NCDs, or for all non-communicable diseases. The idea also of early exposure to carcinogens having a sensitive period where cancer rate would be greater later on. Of course, the role of body composition inducing hormonal, metabolic, and inflammatory responses as being also important in the cancer process. When we're seeing that obesity and rapid weight gain are also linked to enhanced linear growth, and they may affect also some cancer risk. And as we talked about, food preferences and activity patterns are defined early on in life. I think as a model, the model of the hormonal exposure of mothers is probably one of the best models because it was linked to the appearance of a very rare tumor, in this case, vaginal adenocarcinoma, that was evidenced, in this case, by one gynecologist that over a year had 6 cases of a cancer that he would have seen, he would have expected to see once in his lifetime. And Dr. Herbst put it together, looking at the records and showing that this was associated to maternal stilbestral therapy. And then in the next generation, the girls developed this very rare cancer. This is really proof of principle. It's not public health relevant, but is to point out that even in this case, this rare cluster was very, very much linked to an early exposure. Interestingly, in the US, the study of the exposure of only a group of 10 newborn children that in examination of their cord blood found 287 chemicals that were not supposed to be there, and 180 were already demonstrated carcinogens, led in fact to a public upheaval that it now has led the NIH as a core effort across the institutes to look at the burden of both malformations and cancers linked to early exposures. And that is called the Children's Study. And for the first time, we will have a cohort of 100,000 children being generated as we speak, that there will be life course exposure studied, and we will have the opportunity to look at gene environment, gene nutrient interactions to really pinpoint this in a comprehensive manner. This is probably one of the most ambitious projects, very expensive, and it's very controversial because the communities, in fact, are being selected and there's relative merits for this process for various communities. But in fact, I think for the first time, we will be able to answer some of the key questions with the life course approach. The endocrine disruptors are in the press almost every other day, telling us about dioxins and products that may be in both in our foods and our environment, both in terms of intended or unintended uses. And of course, in the case of the dioxins, the evidence does exist for it having a high effect in terms of potential carcinogenesis. And the worst is that there's really there's no dose response. There's really no safe dose for dioxins from what we know. Moreover, the burden of dioxins that we get comes mainly from breast milk in terms of a life load that it remains in our body with the adipose tissue. So the implications of this may be that at any time in life, we may be subject to the effects of the burden that we have generated early on in life. A good example of this is from an animal model showing two dioxin-like compounds that are endocrine disruptors in a rat model and the effect on postnatal development of the breast. And you can see this was exposed during late gestation to the atrazine or to the TCDD at doses of 1 microgram per kilo. This is a very, very, very low dose. And you can see here that prenatal exposure was linked to abnormal mammary gland tissue development, and you can see that this becomes progressively more evident with advancing postnatal age. So a prenatal exposure carries out and actually plays out later on in life, creating the setup for a high risk of cancer from this endocrine disruptor. This is in the lay press, and of course, all sorts of environmental pollutants may be present, both in the plastics, both in the pesticides, in some of our foods, such as grilled meats, but we really do not know fully how risk can be avoided. And of course, this is something that can be measured only if you're following the people with the exposures over time. Based on animal data, though, we're seeing that some of these compounds have become the focus of attention. This was in the press in the last couple of years. It has not gone away. These are plasticizers to make plastic soft, and they're used in bottles, including children's bottle. And now there's obviously the concern that although there's already a safe limit that has been proposed by EFSA, that is quite low. And the question, how can we avoid these exposures? And these are some specific recommendations given by the US NIH Environmental Health Science group. Obviously, the polycarbonate plastics in microwaving might leach these compounds and will be potentially a problem. And so the idea is try to use glass, try to use foods that are not in contact with these compounds in their storage. So for example, powdered formula versus liquid formula, the content of the BPA is greater when you have liquid formula being heated. And baby bottles are BPA free, use of glass rather than plastics in storage of food, and heating of foods come from this type of knowledge. Probably a stronger area is how the growth and the early diet may condition latter risk, both in terms of hormonal responses and also in terms of body composition. This is data from Isabel dos Santos at the London School of Hygiene and Tropical Medicine, looking at the source of information to analyze the birth weight data. So if you take the adult reports, cases versus the rest of the population for birth weight, you find no effect. If you find and ask no effect of birth weight on in this case, breast cancer rates, if you ask parents to recall the weight at birth, and you're asking women at the time of looking at their children's birth weight, you also have no effect. But if you go and look at birth records, you find an effect of birth weight, a 12% increase of birth weight over 4 kilos on, in this case, breast cancer. So the source of information that you collect of the early life events becomes crucial, thus the importance of having longitudinal follow-ups where these records have been collected systematically. Looking now at birth weight increments for 500 grams, and if you look at this from data that is based on birth records, you have for each 500 grams increased birth weight, a 6% increase, which is significant too. Albeit small, this applies to the whole population. And birth weight, increased birth weight is a trend that we're seeing, and very specifically, we're now seeing around the world with maternal obesity, increases on macrosomia, birth weights over 4 kilos are no longer unusual. In many countries, 10 to 12% or more of children are being born with birth weights over 4,000 grams. Now, birth length, and this again is data coming from birth records, by every 2 centimeters is associated with a 6% increase in breast cancer. So it's not only weight, but it's length, and it may well be the hyperinsulinism that babies that are macrosomic are exposed in utero, and the higher IGF levels that they actually have. Now, the other issue is, of course, the linkage with obesity and the exposure, in this case, being breastfeeding, being a protective determinant, being a protective factor for obesity. By now, the World Cancer Report did agree with the evidence that there was a significant benefit from breastfeeding in terms of prevention of obesity. This is a systematic review looking at a meta-regression, duration of breastfeeding versus obesity rates, and you can see here that there is not a perfect dose response, but the relationship is towards more prolonged breastfeeding associated with lower rates of breastfeeding. And these are various studies, mainly in Europe, but also some from developing countries. How could this be related? And this is now a more careful study done by the CDC, by Larry Gummer-Straw, looking at the intensity of breastfeeding. So within the breastfed, those that had more often and more duration, and also the pattern that emerged after 6 months in terms of emptying the bottle of the baby, getting and being encouraged by the mother to fully empty the bottle. So the question that he asked, how often does your baby drink all of his or her bottle? How often your baby drinks all of his or her cup of bottled pump breast milk? How often do you encourage your baby to finish a bottle if he or she stops drinking immediately before the formula is all gone? And how often is your baby encouraged to finish cup or bottle if he or she stops drinking before the pump breast milk? So here is the behavior of emptying the bottle that is induced by the mother. And this is the data. This is excess weight for age beyond 1C score, and this is no excess weight for age. And these are the behavior. Breastfeeding intensity. So if it's low, we see that there is actually less excess weight if the child has high intensity. If the child has high intensity, there's also more no excess weight gain. So in fact, we find that breastfeeding intensity is protective. The frequency of infant-initiated bottle emptying is also significant in terms of if the child does often empty the bottle at the high tertile, he will, this is frequency of infant bottle emptying. If he does it rarely, there's more no excess weight gain. If he does it often, there is less excess weight gain. So emptying the bottle is associated to more obesity. In the same study, there was also the analysis of age of introduction of first solid foods, and it was also seen that if there was no excess weight gain, the first solid food was introduced later. and also the number of sweet drinks, in this case, was not significant, but in other cases, when sweet drinks are introduced quite early on, it's also associated with increased obesity. So we're seeing here that both the Breastfeeding Act and the behavior of mothers towards encouraging full consumption of the bottle is associated with increased obesity. So this is a summary from the study that, in fact, forcing, let's say, in a way, forcing the normal regulation the child has, especially with breastfeeding, a child will take about 20-25 minutes to breastfeed. If he's bottle fed, he would normally take half that time in getting the equivalent amount of food. So the satiety mechanisms that are placed in the Breastfeeding Act, even though you may be feeding the exact similar component, will have an effect on satiety. Now, this is another study looking at how children accept solid foods, in this case, vegetables and fruits. This is from the Monell group in Philadelphia, and you can get a sense of how babies like or dislike the foods based on these 6 standard responses. So this is brow lower, inner brow raiser, nose wrinkler, upper lip raise, and gape, the 6 behaviors. So now these are children being exposed to green beans after 8 days of home exposure. The before and after, in fact, is not very different. This is the number of the type of movements after you offer 1 spoon. So this is the cumulative number per spoon offer. Now, if that child, instead of just being given the green beans, is giving green beans and peaches, you see a dramatic difference in the before and after the 8-day exposure. So exposing to a variety of foods has a beneficial effect in the acceptance of the variety of foods. What's even more interesting comes from the acceptance of foods if the child has been breastfed. And in this case, you can see peach consumption the first time it's offered if a child is breastfed in terms of infant consumption in grams versus if the child is formula fed. It's virtually half of that, and this is significant. And the idea here is that people have actually measured the taste components of breast milk is changed by the maternal diet. So if the mother eats peaches, the baby will get peach flavor in the breast milk. Similarly, in this case, the state expression when first fed, if the child has been breastfed, there's less the state's expression. So not only he will take more, but he will like it more in terms of those measures. If the mother has been eating the fruits before the week where he was exposed, there's also, in the lactating mothers, number of fruits consumed relates to the acceptance of the child. So in summary, breastfeeding confers an advantage in initial acceptance of a food, but only if the mother ate that food regularly. Once weaned, infants repeatedly exposed to a food eat more of it and may learn to like its flavor. So that's why it's so crucial to introduce the foods at the right time. And obviously, the facial expression, in fact, sometimes would disencourage mothers to stop to give the food. The idea here, though, is that mothers should insist repeatedly offering the fruits and the vegetables so that based on the willingness to continue the food and not on the face express of the child. Now, we are doing, over the last 6-7 years, a cohort follow-up in Chile looking at children born in 2002, looking at their detailed anthropometry, their weight gain, their height gain, looking at their body composition at various ages with non-invasive methods, and looking at their bone age, at their hormonal maturation based on the use of ultrasound, non-radiological measures that allow us to know the age of maturation. And that also includes body composition then and measurement of bone age. And we're also following their families. I'll just show you one bit of information. This is BMI of the children that at age 7 were considered obese, overweight, and normal. And you can see the phenomenon that has been described already by Roland Cachera of the adiposity rebound being very, very early. In the Roland Cachera data, she called early adiposity rebound as children who had rebounded before age 4. In fact, we're seeing the adiposity rebound in the obese children, in this Chilean cohort, somewhere between 2 and 2.5 years of age, very, very early. The overweight are rebounding at around 4 to 5, while the normal are rebounding after age 6. So we have here a biological marker that in fact is linked to the obesity rate. So those that are obese at age 7, 52% rebounded at below 2 years of age. Why is this important? Fast growth very early on then is linked to an early adiposity rebound. It's linked to early obesity rates, and this now is being completed in terms of its meaning to central obesity. We already have metabolic markers showing that feeding fast and rapid weight gain are associated to the central obesity syndrome, and most likely there's already emerging data, and we expect to get more from our cohort, to early pubertal maturation. In fact, what we're seeing is accelerated telarchy even in the absence of the fuller tanner. So breast development, both of the adipose tissue and potentially of the breast tissue, is accelerated by the fast feeding and the fast energy gain. And in fact, when we're doing the bone age maturation, we find that adiposity gain is associated with advancing bone age maturation. So in a way, these populations are potentially being set for early maturation and increased risk, specifically potentially for breast cancer. This is data from Japan showing the transition in height. The gain in height after the war has been very closely linked to the incidence of breast cancer, and data from the Harvard group following that suggest here that the attained height may be linked to the breast cancer. This is from the report showing that, in fact, breastfeeding is associated to decreased postmenopausal breast cancer. The importance here is that lactation can reduce up to 25% the risk of maternal breast cancer. Now, with the food and water being relevant, there's also the interest of other exposures related to early life. This is data from Chile showing at the time that the water arsenic was being monitored and that the preventive measures were taken over this 15-year age period, you can see that there's a lag with the appearance, in this case, of lung cancer. The interesting data, though, is depending at the age of what the population was exposed. If they were exposed at infancy, the cancer rates for lung cancer related to the low arsenic were about 13 times. If they were in childhood, they were about 12 times. If young adulthood, 8 times. For middle-aged adults, 4 times. So the same period of exposure at different times had a significant impact on this case of lung cancer related to the arsenic. So in summarizing this evidence, we can see that a combination of the specific exposures during critical periods may confer increased risk for some specific cancers. Modification of the early diet, nutrition, growth, physical activity may help reduce this risk. Following biomarkers may help predict how effective can the interventions be. Such an approach should be part of strategies to enhance the effectiveness of intervention, focusing on risk reduction at critical times. Of course, we're going to die of something sometime, but as already Phil showed, this is what happens in risk reduction for all death causes at 5 years from the data of bariatric surgery. And this data, with very massive weight losses, 34% mean BMI reduction, follow up to 5 years, shows that for cancer rates, for that population, the cancer rates will reduce 76%. So you can also do something in the adult years. The longer-term data coming out of Sweden is shown here, again, with massive either gastric bypass or gastroplasty or banding. You can see also that the risk of cancer is reduced by about 50% in the group now on a 15-year follow-up. There are many mechanisms that can explain that. So it's not only about the cell growth, it's inflammatory responses, DNA repair, apoptosis, cell differentiation, hormones, and carcinogen metabolism that can be modified by the obesity. And of course, epigenetic phenomenon, either by the histones or by modifying the bases in the DNA, can define the levels of a gene expression. And in a very interesting model, in this case, a agouti obese mouse, depending on the degree of methylation of the specific sites, you can actually, these are all genetically the same, but you can get the animal to be a pseudo-agouti, namely non-obese and with the skin being pigmented, related to that trait. You can follow the level of expression by the dose of choline, folic acid, B12, and betaine provided. So here we see nutrition manipulation of epigenetic changes defining the rates of obesity. This is another experiment in nature in Holland at the time of the famine. We can see right here that the famine was preceding the liberation of Holland, and the group that was exposed periconceptionally has a decreased level of methylation, in this case for the IGF-2 gene, whereas the ones that were exposed late in gestation had no effect. This is the summary of that paper published in PNAS, for those that have not seen it a couple of years ago, showing then that there was a very specific association of degree of methylation linked to the time of exposure to the famine. Follow-up of methylation studies now on rats for subsequent generations showing that obesity is linked to the epigenetic changes. In fact, they can be prevented by increasing methylation by administering folate and B12. So this is something that can be manipulated by nutritional interventions. We still do not know the full meaning of this. My last couple of slides showing that we now need to accept that during development, the same genome can express into various phenotypes. This is not a new concept, but now we have the understanding then that the gene is not a destiny, but it's a map that can be read in more than one way. And in terms of adaptation, homeostasis is a minute-to-minute change, but you can also have developmental plasticity in the way you utilize substrate, define growth rates, define hormonal responses. And finally, selection that occurs over millennia is the final way we adapt to changes. So as we see the obesity epidemic, a lot of what we're seeing in terms of biological effects on disease are linked to this developmental plasticity, both in utero and ex utero. So coming back to our initial slide, basically we can do things at the stage of fetal life. We can do a specific preventive measure during infancy and childhood, during adolescence, and during adult life. So this would be a life course approach to preventing risk. We do not know the exact shape of this curve, but most likely this will be more vulnerable than later on in life. And if we're able to be successful in the ideal world, we'll get to genetic susceptibility as being the main cause of cancer. Thank you very much for your attention.